we decided to start doing this together, and provide that on the ground firsthand experience. Mindy, do you want to say more about who you are or how you came to do these trainings with me?
Well, just basically a really difficult time in rural Utah that turned into something good when trying to do harm reduction. And thank you, Dr. Page, for the introduction too. And I'm just really grateful I get to come and present with Dr. Madden. She's incredible. The work she does is incredible. She's such a genius, and I love to get to do this with her. So thank you, Erin, for letting me present with you.
No problem. Okay, so I'll be providing kind of like some of the academic perspective. This is what my research area is, and Mindy will be providing a lot of that on the ground firsthand experience of providing these services. So just to get us started off, we have no conflicts of interest to disclose. The initial kind of training that this was built on was funded by the USDA NIFA, the National Institute of Food and Agriculture, because we initially developed this training to be a harm reduction and pharmacotherapy training for people doing treatment work in rural Utah, and have since that first training adapted it to a lot of other populations, general healthcare providers, probation and parole officers, etc. But that was the initial funding for this training. We'll start with some introductions. People can introduce themselves in the chat. And then I'm going to go over some terminology and data, both national and New Mexico data. Then Mindy will introduce us to what is harm reduction and talk about 3 essential harm reduction interventions. Then I'm going to talk about pharmacotherapy, some of the barriers to services that people have with pharmacotherapy and harm reduction. And then we're going to have a more interactive component where we start to talk about how could harm reduction look in your work? Is that a possibility? And then we'll have time at the end for questions. We are going to do a 5-minute break halfway through after the first hour, so don't worry. Okay, so if you don't mind, we would love to see who's in this training today, just listing your name, where you work or what you do. And if you feel like it, you can also say a little bit about why you decided to attend this training. Mindy and I sort of started doing this training together because of, like I said, I have that academic perspective, but I don't provide services. So Mindy can speak to what it's actually like to do this work. I can speak about the research on this work. And we initially started doing this because there was a lot of misperceptions of harm reduction and pharmacotherapy in rural Utah treatment sort of environments. And we wanted to address those misperceptions more. So that's how we came to this. I'm so excited to see all the people coming here. So we see we have people from Emory, wonderful, Cuba, New Mexico, awesome. So like, TRC. So like Dr. Page said, I lived in New Mexico for 7.5 years. I just moved in December 2020 and miss it so much. So sometimes you'll hear me referring to us or our state, and I'm talking about New Mexico, even though I'm in Detroit. I still feel that my heart is in New Mexico.
And I'm an honorary New Mexican, and everything I learned from the New Mexicans. And you can, when you talk to people in harm reduction in New Mexico, I'm Mindy from Utah. If you ask some of them about me, I'm Mindy from Utah. They know me, and I'm matching tattoos with them. I'm so excited. There's so many New Mexicans in here. Yes.
Yeah, wonderful. Thank you all so much for being here. So we're just going to move on, but keep introducing yourselves in the chat so everyone can see who's here, and y'all can network or connect with each other through the private message function in the chat if you'd like. So we're going to start by talking about some terminology, then get into some data and trends. So terminology is really important when we're doing harm reduction and substance use work in general. So in this presentation, we're going to be using updated terminology for both the use of drugs and for people, diagnosed with substance use conditions or who use substances. So when we talk about the use of drugs, in the past, we often used to say things like substance abuse, but that was criticized because abuse is really a term that is about the mistreatment of people, living beings, right? So can you really abuse a substance? No, you can use a substance in a way that's risky or harmful, but that's about it. So instead of saying substance abuse, we will be saying substance use. Instead of saying clean or dirty, referring to syringes or needles or urinalysis, We're going to be talking about used or unused for needles and syringes, or substance use or substance free for your analysis. Because again, that clean and dirty dichotomy, that sort of those language choices kind of have bad connotations to them. We don't want people to feel like they are dirty just because they're using drugs. So moving away from that terminology. When thinking about substance use conditions or diagnoses, the word addiction was used in the past and is still largely used today. Some people don't like that word. I tend to still use it because it's what most people understand when you talk about substance use disorders or substance use addiction. Is sort of, you're talking to the public, a good word to use, but some people don't even like that. But we've definitely moved away from drug dependence, drug abuse, or drug habit, and in favor of what the DSM-5, the Diagnostic and Statistical Manual, labels substance use conditions to be, which is a substance use disorder, or SUD, and no longer differentiating between use or abuse and dependence, because dependence alone is not enough to meet the criteria for substance use disorder, and sort of use and abuse, it kind of depends on how you're using in order to meet it. So within that broader umbrella of substance use disorder, SUD, we have, of course, particular types of substance use disorders like opioid use disorders, alcohol use disorders. So we'll be talking with those acronyms a lot today, so have those in the back of your mind. Also, we talk about individuals and people who use drugs. We no longer use terms like addicts, abusers, or even users, and instead prioritize using what's called person-first language, which recognizes, these are people who are doing something, but first they are people, so recognizing their humanity. So saying things like people who use drugs. Of course, people who use drugs sometimes refer to themselves as addicts, right? But that doesn't necessarily mean us as professionals should be using that terminology. So we're going to be using the updated terminology. And talking about, overdose and the drug poisoning crisis, it's important to think about how that affects the United States nationally, as well as how, it's affected New Mexico in particular. So, of course, across the US and in New Mexico in particular, we've seen a pretty significant increase in deaths due to alcohol and other drug overdoses over time. New Mexico's rates are higher than the US rates, even though we're, again, a small state. In 2019, New Mexico lost 600 people to alcohol and other drug overdoses. Nationally, over 70,600 people were lost. So definitely a significant problem, including in the state of New Mexico. And when we're thinking about types of drugs, of course, opioid overdoses are increasingly responsible for drug overdose deaths, both nationally and in New Mexico. So in New Mexico, over time, we see some noise in that trend, but the overall trend is an upward trend of deaths due to overdoses in the United States as well. In New Mexico in 2019, there were almost 400 deaths due to opioids, and 65% of all overdose deaths were then due to opioids. In the US, just under 50,000 deaths were due to opioids. That's about 70% of all overdose deaths that I was showing you in the last graph. So opioids are going to be a lot of the focus today, but with recognition that other drugs absolutely matter, and we should be thinking about them too when we're talking about harm reduction work. The CDC talks a lot about which opioids are kind of fueling this drug poisoning crisis, and they talk about 3 waves of opioid overdose deaths. So this first wave is a sort of rise in prescription opioid overdose deaths. Though I will say there's been some debate over how good those numbers are, were those truly all prescription opioid overdoses or not, but that debate has not really shaken itself out yet. But that's what the CDC calls this first wave, is a rise in deaths due to prescription opioid overdoses. Then we see around 2010, what they call the second wave, which is a significant rise in deaths due to heroin. And then the third wave, and starting in 2013, which is a rise in opioid overdose deaths due to synthetic opioids like illicitly manufactured fentanyl, which I'm sure all of you have heard about, a very powerful synthetic opioid that is now responsible for the majority of opioid overdose deaths in the United States. So one question I have, so we're going to do some polling throughout this presentation to keep you engaged and make sure that you're, feeling included and sharing your opinions. So of course, the CDC data are representing national death trends. So one question I have, and Mindy and I have posed to other groups in other states is, do you think your state in New Mexico, have the recent opioid overdoses followed that same pattern of a growing role for synthetic opioids like illicitly manufactured fentanyl? So yes, do you think synthetic opioids are increasingly responsible for New Mexico overdose deaths? I'm not necessarily saying the majority, but are these playing a bigger and bigger role? Or no, do you think New Mexico has avoided the fentanyl problems that we're seeing in like New York State, which has a huge fentanyl overdose problem? So we'll keep it open for another like 30 seconds. Mindy, in Utah, what do you think for fentanyl overdose deaths?
I think it took longer for fentanyl to get to the West Coast. However, we find it in all sorts of things here, including meth, which just doesn't even make sense. And because it doesn't belong there, nobody's trying to get fentanyl when you're buying meth, and I really, as a past drug maker and drug user, I don't understand why somebody would cut methamphetamines with fentanyl, and it's just rude. I don't even know what else to say. It's like, that's giving somebody something we're not even signing up to get. And this is maybe somebody who's completely opioid naive. So yeah, it has definitely hit us here. It just took us longer.
Yeah, so we're going to end the polling. Thanks for that, Mindy. So it looks like a lot of you are on the same page as Mindy and think, yeah, it's hitting New Mexico now. And I think the data show that it took a little longer to hit here. I keep talking like I'm in New Mexico. Hit in the West, but it is now here, yes. So what I'm going to show you is that, yes, New Mexico is being hit by synthetic opioid overdose poisoning. So in New Mexico in 2008, 22 deaths were due to synthetic opioids, which is about 4% of all the overdose deaths in 2008. Across the United States in 2008, it was like 2,300, which is still very low. In 2019, these rates are much, much higher. We really are seeing huge growth here, and this is a huge problem. So deaths in New Mexico in 2019 due to synthetic opioids, that is now 25% of all of our OD deaths, our overdose deaths in the state. So about 150 deaths due to synthetic opioids. Across the United States, the rates are higher. So over 36,000 people died from synthetic opioids in 2019 alone, which is about half of all overdose deaths across the country. So this is absolutely a growing problem. New Mexico is not quite as bad as other regions, but the problem is growing and we need to be aware. And also, it's not just opioids, right? There's, as Mindy mentioned, deaths due to using both opioids and other drugs at the same time. So this is data showing sort of deaths due to opioids and what's a class of drugs called psychostimulants, which include cocaine, methamphetamine, MDMA, prescription stimulants. And what we're seeing is that over time in both the US and New Mexico, a rising trend too of people dying from polysubstance use. So in 2019 in New Mexico, 191 people died of mixing opioids and psychostimulants, which is about a third of all New Mexico overdose deaths. Across the US, it was more like 27% of all overdose deaths. So we're actually doing worse in New Mexico on this metric than the general national trend.
Can I say something really quick, Erin?
Go ahead.
One thing I was thinking of as I was looking at this is that these are deaths, right? So New Mexico in particular, you guys have a great naloxone distribution. You have great naloxone distribution in that state. If you're from New Mexico, you might not know how advanced you guys are in drug policy and how much you paved the way for the rest of us to even offer these kind of services. So because of your naloxone distribution, I wonder how many lives get saved that way, but are still poisoned by fentanyl. Because there isn't, this data doesn't account for that, right?
Correct, Minnie. That's a really important point, is that we don't have an estimate of that, the non-fatal overdoses. That would be not the CDC death records. I'd have to look for other data for that. The state would have that. But you're right, Mindy, it's that a lot of people are being saved, which is great. Yeah. So this doesn't capture the full extent of the problem, is what she's saying, and that's absolutely right. And so in New Mexico too, I mean, we have these drug poisoning problems. We also, as Minnie said, have a better than average harm reduction and treatment profile, but that doesn't mean that there's not more that needs to be done. The New Mexico Department of Health has estimated the treatment gap in the state. They estimate about 204,681 people are living with a substance use disorder in the state during 2018 when they last did an audit. And they found that about 39,000 people within that had an opioid use disorder, 101,000 people had an alcohol use disorder, but only 70,000 or so people were receiving treatment in 2018, which is suggesting a treatment gap, an enormous treatment gap of 134,000 plus people needing but not receiving treatment services. We have no clue also where the gap is in terms of harm reduction services, which are not measured in these treatment gap sort of studies. We don't know how many people need those who are not getting them. But we do know is that, right, we have at least a treatment gap. Probably people are also experiencing a harm reduction gap. So, this is a problem. There's a national drug poisoning crisis, but not everyone at risk of overdose is also ready or able to enter treatment. That treatment gap slide is important. We also have to recognize that not everyone's ready to go to treatment. They don't necessarily want to go to treatment. So one question is, like the $1 million question, what can we do to improve the willingness and ability of people with substance use disorders to get treatment? And for people who refuse treatment, what should we do? I would argue the question of ability to get care requires, significant structural, that means policy changes and things like paid sick leave, investment in treatment services, making sure insurance and care coverage is sufficient. New Mexico has expanded Medicaid, which was a great step in this direction, but other states, Texas, do not have expanded Medicaid. People can't pay for services, which is a huge problem. But the question of sort of willingness to get care and like treatment refusal are slightly different. One effective approach to improving people's willingness to engage in treatment and help people who are not interested in stopping drug use is this thing called harm reduction. So I'm going to hand it over for Mindy to talk about what this is and how we can use it to help people.
Dun, dun, dun. Hello, friends. So I will go over these slides. Aaron, can we go to the next one? Okay, so it seems from the introductions in the chat that probably a lot of you are familiar with harm reduction, it sounds like. And so I won't get too crazy over the definition of harm reduction, but there is no single definition for harm reduction. However, to me, I think that harm reduction is anything that we do that reduces harm. And I hear people use examples like sunscreen, seatbelts, those are all ways to reduce harm. So they're technically harm reduction. But from a clinical perspective, there are a set of evidence-based strategies that we use to reduce the negative and social consequences and physical consequences associated with substance use. Also, you can't really do harm reduction without talking about the social inequities and reform that needs to be made in criminal justice and social justice as a whole. And I already said that part in the beginning, sorry. So we'll skip to the next slide. So what are some harm reduction strategies? So an important part of harm reduction is we meet people where they're at and we don't leave them there. That's the most important part. When I'm doing harm reduction, people have this idea that I just endorse substance use. And the reality is I don't get to decide what anybody does or does not do, not as a treatment provider, not as a sponsor, not as a friend. I don't get to decide, but I do get to create a place that is safe for people to be honest with me so I can help them when it really comes down to it. And just a little piece of how I became a harm reductionist. My older sister died of an opiate overdose in 2014. And it was actually would have been her 45th birthday the other day. And not one time have I, since I lost her, have I ever thought I should have been harder on her. I should have held firmer boundaries. I should have done this or that. All I can think is all the ways that maybe I could have helped her to stay alive. Because I don't think usually that it's a matter of people not being interested in stopping substances. I don't know if they feel like they can. And none of us have been in somebody else's place or position. So we don't know what the things are that trouble somebody, that haunt somebody, that traumatize somebody. And there's so many things that go into how people become addicted and their ability to recover, which we'll get into that in a few more slides. But so we have to consider that. So it is a means, harm reduction is a means of promoting safer drug use. Ultimately, we don't want people to die. And it supports people seeking abstinence or even lessening their drug use through treatment. I need to move my little guy over here. Hold on. I'm going to make the screen, I'm going to make the pictures go away because they're cutting off part of the slides. Okay, so part of harm reduction, or part of what is not harm reduction, is things like punitive policies for drug use. I saw that we have a lot of people who work in drug courts in here, which to me is amazing. I'm a graduate of felony drug court here in Utah. I'm a huge fan of drug courts when they are utilized for high risk, high need people in the right ways. But oftentimes drug court is a good example of punitive punishment for people who are struggling with substance use. Taking away people's children. When you put people in jail or prison, you're cutting off all of their protective factors, and you're increasing their risk factors. So even though there's some good things that can come from incarceration for some people, ultimately we're causing more harm than not. Expectations, all people should want to achieve abstinence, or the abstinence is the goal and that's the only way of recovery. That's not harm reduction. And the belief that people have to hit rock bottom in order to recover kills people. Rock bottom is death for many people. And for people who are in recovery or who have recovered from a substance use disorder, then you probably know that rock bottom has a trap door anyway. So rock bottom is a terrible fallacy that we spread. Next. Harm reduction is more than a collection of interventions. We're going to go through some of those interventions, but it's also a set of values that guide, and like it's a baseline of how we provide care. So there's 8 key principles to harm reduction is outlined by the Harm Reduction Coalition, the National Harm Reduction Coalition. A lot of states, including Utah, we have the Utah Harm Reduction Coalition, but this is all from the national one, and I think we all take from them. So we accept that drug use is just part of life. It's always going to exist. And you know what? It's not necessarily a bad thing either. Like substance use in and of itself is not necessarily bad. All people, I would argue, medicate in some type of ways. And as human beings, we're hardwired to seek pleasure and avoid pain. So, and drugs do bring pleasure. So I think that we have to accept that for very reasonable reasons, it is always going to be a part of our world, and that we should work to minimize its harmful effects instead of telling, it's like when you tell teenagers, don't ever have sex, right? And then you don't give them any condoms or any way to prevent pregnancy or sexually transmitted infections, then we see high pregnancy rates. So drug use encompasses an entire continuum of behaviors that is over here is chaotic use, and it goes all the way over here to abstinence. And there is so much in between. And just because somebody uses a substance, even a hard substance like cocaine, even heroin, doesn't mean that they have a substance use problem or a substance use disorder. If you have Dr. Carl Hart, who is he's like the head of psychology or neuropsychiatry and psychology at Columbia University. He recently came out with a book called Drug Use for Adults, I think is what it's called. But in that book, he talks about his own heroin use and that he is a recreational user of heroin. Now, that's hard for me to imagine, like shooting heroin on occasion. To me, that as a therapist, it's hard for me to comprehend how that's a healthy coping mechanism. However, his life isn't falling apart. So he's a good example of like that there is exceptions to what we in substance use treatment think of as the rule. And that there really is this entire spectrum that is so long. Ding. So when we're deciding about if our interventions are successful, we base that upon people's quality of life. We often say any positive change is good. And in recovery is any place that's better than the one you came from. So if somebody comes to me and says, you know what, I want to stop shooting heroin, but I'm still going to, sometimes people are maybe I'm going to smoke heroin, but they're like, I'd really like to address having somewhere to live. I'd like to get more connection in the community. If we achieve those things and they're still using heroin, that's still on some levels, well, from a harm reduction standpoint, it's completely successful. However, I think from a clinical standpoint, we could probably go a little further with it. Theory has now been tested widely. Oh, see, I got to read this really quick. But the widespread availability of opioids, boom, what has happened has been shown to fail miserably. I can see that. Like, I would never encourage somebody to like recreationally use heroin, because I feel like it's just really dangerous, and there's got to be other ways you can feel better besides using heroin. But So number
That would
4,
be me, Mindy, who put that in there.
thank you. I have the pictures closed because I
So
couldn't see
I'll
all
just tell everyone my theory. I think Carl Hart's premise has been shown to fail miserably. We've had widespread availability of opioids in the US for the past 10 years. And if anything, it's been shown to fail miserably. People cannot all control their opioid use.
Well,
So
and when
he's
you look
getting discredited.
Well, when you look at people though who get prescribed opiates just for pain, but then, dependence and addiction are two different things, right? But when you see people become addicted to them, it's not necessarily because life was so bad before. It's because when they took that pill, it just felt a little bit better, you know? And I think that's the slippery slope that leads to addiction. That's why I myself would never encourage somebody to like use heroin recreationally. But again, I don't decide what people do, right? People are going to do what they're going to do. And I can just offer them tools and support and love to do something different. But that's where we're meeting them where they're at, but not leaving them there. Harm reduction calls for non-judgmental, non-coercive provision of services and resources, which is sometimes difficult because so often in this country, we've just been taught to respond to substance use with punishment. So it's really hard for people to fathom not using coercion to get people to behave a certain way. So I would like to see people with substance use get treated more like someone with diabetes, right? Like when somebody cheats on their meals with, or has to use more insulin or goes into a sugar coma even, or a diabetic coma. I'm not a doctor, so I don't know all the right terminology for that, but we don't cut them off their insulin. We don't scream at them in a group and tell them how they're a piece of shit and they're destroying the lives of their family and everyone around them. We continue to treat them. We use harm reduction with them and try to help them maintain a better diet, try to help them check their blood sugars more, right? So I'd like to see people with substance use disorders get treated that way. We do not UA people with diabetes when they come to the doctor to see if, what they've been eating. We UA people with substance use disorders all the time because we just believe this lie that they are inherently liars, cheats, and thieves. And that's just not accurate. And while we believe those things, we're not going to have non-judgmental, non-coercive services. Number 5 is that we ensure that people who use drugs routinely get to participate in creating the programs. There's a famous saying, nothing about us without us. One of my favorite things about that in substance use is that so many people recover from substance use disorder. And so many give back so much. So we have this ability to have people, we can work with our participants who are actively using. We have this huge group of people, my whole staff's in recovery. So we have this whole group of people who did use drugs for a long time and now are in a better place. And they have some ideas about what could have helped them then and how they, what we can do to help people still now. So people are their own primary agents of change. People who work in the clinical field know that shame might help people change for a really short period of time, but ultimately shame doesn't change behavior. People themselves have to want to make some change. So we empower people to be the deciders of their own life and empower people to make decisions that get them where they want to go. We recognize that there's socioeconomic factors to both addiction and people's ability to recover from a substance use disorder, poverty, class, racism. There's so many things that play into that one. And that's part of the social justice piece of harm reduction, is that if we don't address these other issues, this is why drug use is always going to be a part of our lives, because people have to escape the reality of what their life is. But we do not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use, which I think many people often misunderstand when we're talking about harm reduction. Like I said, people think that I just high five people, give them syringes, and I hear there's good dope out, have a great weekend. And that's not the case at all. I just shared that I lost my big sister to an opiate overdose. I myself was addicted to meth for 17 years. I lost custody of my son twice. Like, I would never ignore the dangers that come with substance use. And if we don't ignore them, we can really address them, and then we can really save lives. Because if people are dead, we can't help them do anything. So initial reactions to harm reduction so far. Are we putting up a poll? Oh, there it is.
So yeah, I also wanted to add on to what Mindy just said. I think a lot of even people who work in research on harm reduction get accused of encouraging drug use or not thinking that drug use is that big of a deal. And what Mindy and I always say is that everyone we know who's involved in harm reduction either is a person who used drugs and potentially almost died from that use, or knows people who died. I have lost a family member and 3 friends to overdoses since 2006. I care about that. It is not the fact that I don't care or think that some types of use are dangerous. So that's a common misperception. I think a lot of us care deeply and we just think this is the way to deal with the problems that they had. Yeah. So Mindy, you can we'll maybe leave the poll open for another like 10 or so seconds if you haven't voted.
Okay. And I want to throw out there, you know, the term enabling, you hear it a lot when you're talking about substance use. And I used to be, you know, enabling is a touchy term, but overall, I really don't believe in enabling, because people are going to make the choices that they're going to make regardless. Right. And what I enable is I enable people to be honest with me. I enable people to save their own lives. I enable people to do what they're already going to do in a safer way. So I would just really, for those of you who believe strongly in enabling, you know, ask yourself, have I ever been able to cause somebody to use? You know, because it's funny, because it doesn't usually go both ways. People are not like, yeah, I'm responsible for their drug use. Yep, I said this to them and they went and put a needle in their arm over it. You know, just like you don't have the power to make somebody use, none of us have the power to make somebody stop either. And sometimes the consequences we try to give people in the meantime end up really harming them or outright killing them.
Yeah, it seems like most people have positive or at least neutral reactions, which is great. When we gave this talk, a similar talk to probation and parole officers in Florida, this was not the distribution of responses. So it seems that y'all are a little more open-minded to it and see some of the positives, or at least see maybe there's some positives, even if there might be some negatives.
Yeah.
So
well, I feel bad for law enforcement because they're really in a bad position, right? Like people are breaking the law. And so they can't just, you know, it's very hard as law enforcement to be all on board with harm reduction, because it is in conflict with the law. Like it's in conflict with the law in some ways. Like the behavior of the people is in conflict with the law, not harm reduction in itself. But okay, so let's talk about some interventions. This is my favorite part, the interventions. Dun, dun, dun. Okay, so safe consumption sites. So we have run a bill here in Utah the last couple of years trying to get safe consumption sites passed. They're also called safe injection sites. Oh, they have one more name too, and it just escaped me. But either way. So, we call them overdose prevention sites here in Utah because the name safe consumption sites in itself makes people sometimes have a negative kind of response. So we want to limit that because harm reduction already gets people pushing back enough. So let's see, Portugal is to criminalize all drugs. That is true. And you know who has an even better model of decrim is the Czech Republic. So if you ever want to look at decrim, look at Portugal and the Czech Republic. So overdose prevention sites, they allow people to, they have them in Switzerland, Australia, Canada. They're in several places. I've been to all the ones in Switzerland. They allow people to come in and they do like a full intake. They get all their information. When their number's called, they go to a certain area, depends on how they use drugs. So that's why I don't like the term safe injection sites, because it insinuates that everybody's injecting, and that's not true. It also helps push, I think, that fallacy that people that die of overdoses were injecting, when that's not true either. You know, people smoke and die on a regular basis as well. But they use these substances under the supervision of medical staff. They are offered all sorts of, in fact, in Switzerland, they have to do the case management piece. They don't just come in and do drugs and leave. That's not exactly how it works. And they actually have a lot of laws around it too, like how many people can be at the bus stop at one time and all sorts of stuff. But they provide an immediate response to overdose, and no one has ever died from an overdose in a safe consumption site in the world. And there's been, in the one in Canada, I think is it called Inside or On-Site? Do you know, Erin?
no, I know of this Cactus safe injection site the most.
Yeah, well, they've had over 10 million injections done in just the one in the on-site in Canada alone. And, so that says how many people are utilizing them, and also the fact that no one's ever died. That's a big deal. So this is a picture of one, and that's what they look like in Switzerland too. It's very similar. Are they legal? Sort of. So they have passed in several states. In fact, Rhode Island last week signed their pilot program into law. So Rhode Island might end up being the first. Philadelphia actually passed it. Well, actually, Seattle, King County passed it first. And then, but their community, they did not get it going fast enough. And so the community just kept, they rose up and they stopped that. So then in Philadelphia, they passed it through their city council. And then when they were getting ready to open it, well, the federal government filed a lawsuit, and the judge ruled in favor of Safe House, which is the safe consumption site. And so they were told they could go ahead and move forward. The government, of course, filed an appeal, but the landlord got so much pushback from the community that he ended up pulling their lease. So they still do not have a safe consumption site open in Philadelphia. They have passed it in Denver as well, and it is trying to go through the state legislature. We are going to run it through the state legislature again this year, and we're trying to do it in Salt Lake City. But we're all going to run into the same problem, which is that it's in conflict with federal law, even if we pass it in state law. Rhode Island passed it. It's full passed, and they have a pilot program. So we'll see how that goes. But I have a feeling Rhode Island is going to be the first. Are they effective? Yep. Nobody's ever died there. And there's also so many other resources that people get. There's so many other things that people get when they access any of these services. And there are people who maybe otherwise would not even be in contact with us, right? Because oftentimes people are in contact with us once they've overdosed, once they're court ordered to treatment, once they've lost their kids, right? Why does it have to get there before we can help people? I don't know anybody who's strung out on drugs that's like, you know what, this is just the way I want to be, not when you do even a little bit of digging, right? Like, so we have a long way we can move with folks. So the ones that were established in Sydney, Australia, in the first 18 months, 4,000 people who used drugs registered, 1,400 people were referred to treatment. 409 overdoses were attended to, and none resulted in death. And Australia is actually one of my favorite ones to look at, because their safe consumption sites, like somebody just commented, crime went down, the streets were cleaner. And in fact, community members in Australia came forward and actually pushed for more of them because they made their communities a better place. So syringe distribution programs, or you can call them syringe exchange programs, syringe exchange services. They have lots of different names, needle exchange. They are programs that provide free unused needles and syringes to people and all of the works that go with it, depending on where you are. So like the cookers, cottons, tourniquets, we give people wound care kits, naloxone. If we have not saline, but sterile water, we provide that if we can. So we use an exchange model. Most people do use an exchange model. It's usually the type of exchange. So there's one called 1 for 1. You give one, you get one. We have to give out our syringes in unused packaging, which means in their original packaging, which means they come in bundles of 10. So we have a 1 for 1 plus. So if somebody gives me 7, they get 10, because I have to keep them in their package. And some people just have unlimited, which that has been shown through research to be the most effective, because when you restrict people's access to new supplies, then that's when disease gets spread. More benefits to syringe exchange programs. There is so many benefits. Some people who access syringe exchange services are 5 times more likely to enter into treatment. People get naloxone. We have distributed so much naloxone and had so many reversals at UHRC, and all of that naloxone is provided by an organization called Utah Naloxone. They're easily responsible for saving thousands of lives in the state of Utah. So I can't even imagine New Mexico's overdose reversal numbers at this point, since the beginning of your naloxone program. We do get people linked in with treatment for STIs. We can get them PEP, we can get them PrEP, we get them hepatitis C treatment, HIV treatment. We have a harm reduction based outpatient treatment program. We help people get signed up for Medicaid, their housing, all sorts of things. So you can, once you are talking to somebody, the things that you can do with these folks is endless, right? as long as you're not on some kind of timeline to hurry them through. Is syringe exchange legal? Meh. Depends on where you are. And it also depends on how your law was written. For instance, here in Utah, it's legal, and but they didn't carve out an exception in the paraphernalia law. So in some ways, it's like our people who are coming to access syringe exchange, they can be arrested with their supplies on their way to syringe exchange. In New Mexico, you guys have these little cards, which we had them too, but I don't know why our participants lose them and yours don't, but with these little cards, they're exempted from that if they're on their way to or from syringe exchange activities. So that's what we'd like to get here in Utah. And then also depending on what kind of supplies you're giving out, because like we're not allowed to give out the cookers, cottons, tourniquets in certain places in Utah because of not carving out the paraphernalia law. So this is a picture of Georgia and Julie. They're doing syringe exchange this was here in Utah a couple years ago. Some of those supplies might have come straight from my friends in New Mexico. When I say that the work that we get to do here, that it was paid, the way it was paid for us by all of the wonderful humans working in harm reduction in New Mexico, I really mean that. That I literally flew back, I flew to New Mexico to train in syringe exchange there at the Santa Fe Mountain Center. And then, and also in Albuquerque. And when I flew back with all these supplies that they gave me at the New Mexico Health Department. They gave me like Brillos and all sorts. Phil, yes, I love Phil. They gave me tons of stuff, and I thought, oh, how am I going to go through security with this? But they didn't have a problem. So, like the first while syringe exchange was running here, it ran off supplies that were given to us by New Mexico. But we were able to use your data, show what you guys have done there, and how that would translate here to Utah. So, are they effective? Yes, they reduce HCV and HIV, and in fact, the AIDS epidemic in the 1980s was turned around by syringe exchange. That's where it all started. It was in Tacoma, and they'd say, we'll give you, you give one to us, we'll give one to you, and it'll keep you alive. It's like this. Dave Purchase is a guy who helped do it up there. So it does reduce accidental needle sticks in the community. At our organization, we go out and do cleanups every time we do syringe exchange. We also do cleanups outside of that because it's a great way for the community to get involved. And if you want buy-in from a community, then help them make it a better place. So, and it does help people. I get to help people get resources before there's some type of intervention that's harmful to them, that, to where they get those resources in a way that might not be as helpful. Ding. That's my doorbell for the slides now. So safe drug supply, what is it? It's providing medical grade doses of heroin, methamphetamines, or other drugs to people with substance use disorders.
What is the balance?
What? Oh, I thought somebody was asking a question. Sorry. So instead of people buying illicit drugs, then people are supplied with safe drugs, because often I tell people that drugs are not illegal because they're dangerous. They're dangerous because they're illegal. Because when people have safe supplies to things, how often do you hear about pharmaceuticals that came from the pharmaceutical companies that people, besides, people overdosing on them? When's the last time you heard about contaminated Tylenol? I that did happen once in like 1983 when I was a little kid. I remember the little kids Tylenol getting something happening to it. But other than that, you don't hear about that stuff. And when things are regulated and they're legalized, and then there's control methods. And so we'd save a lot of lives if we did this. It's generally only intended for people with severe substance use disorders who've not been successful with other interventions such as medication, treatment, or for opioid use disorder. So Aaron, is this is about like the heroin assisted treatment, right? Could I tell them a little bit about that? I thought that's
yeah. I mean, heroin assisted treatment would be like an example of a safe supply, but of course, because we've been talking a lot, you and I, about also other drug use too, that there's been increasing movement towards like cocaine and safe supply and such. So change.
Yeah. So in Switzerland, and actually in Canada as well, for sure, they have heroin assisted treatment, which it is reserved for people who you have to have been dependent for at least 2 years. You have to have had 3, I think it's 2 or 3 failed attempts on medication assisted therapy, such as Suboxone or methadone. And if you are not successful, they'll put you on heroin assisted treatment where you go 1 to 3 times a day. They give you your dose, you take it right then. It's like literally like going to get methadone, except for it's in a syringe. And they have to give up their driver's license and stuff, but the outcomes are insane. Like, because when people are not having to seek drugs, not only do they're staying alive, right? But people are getting more housing, they're following through with getting jobs, their overall quality of life is improving in these programs they're seeing. Oh, opioid assist. Oh gosh, I wish these could just come out loud so everybody can read what I'm reading. Dr. Page is telling us in New Mexico, they've gotten close to get funding for a demonstration project. Oh my gosh, in the opioid assisted treatment. So would it be, Dr. Page, would this be like, you guys would do like heroin assisted treatment?
Yeah, we call it opioid assisted treatment because more and more programs are using long-acting hydromorphone as opposed to diacetylmorphine. Diacetylmorphine is a hospital grade heroin, but it's very hard to get. You have to import it. It's legal in 7 countries in Europe and Canada, making it 8 countries. So who knows, maybe one day.
Wow. I hope so. If anybody's going to do it, I swear it's going to be New Mexico. You guys are my heroes of drug policy. All right, next slide. Okay, so I was just talking about Switzerland. See, it is 2+ years. And it is limited to 3 doses daily, but they come in the morning, lunchtime, and then in the evening. And I think they're also given a little dose. Well, some people are given a dose of methadone to take home overnight. Yes. Yep. Dr. Page is shaking her head. Yes. So they had an improved retention and treatment. They had a 60% reduction in felony level crime, an 82% reduction in illicit heroin sales, a reduction in HIV, and a total elimination of overdose deaths. So I guess depending on what outcome you were looking for, if your bottom line is let's save lives, this one is effective. In fact, this is true about safe consumption sites as well. They're even more effective than naloxone because some people are administered naloxone and we still can't bring them back, right? If no one has ever died from an overdose in a safe consumption site or in a heroin assisted treatment program, that speaks volumes about what we're capable of doing when we have people close enough to do something. Okay. Friends, we have a poll. Which of the 3 harm reduction interventions do you consider to be acceptable services to provide to people who use drugs?
And I want to specify, because a lot of people in the audience, right, work in healthcare or criminal justice. I'm not necessarily saying, do you want to work in this service? But we're wondering, do you think as a society, it would be okay or useful to have these services available in general? Okay. Later, I will ask about what do you want to work in?
It's okay if you don't love them. The first time I heard heroin assisted treatment, I about flew out of my skin. I was like, what kind of an idiot would give people heroin? I was like, what is going on in the world? And then I learned about what the program was like and I saw the outcomes, and it really, like, when I think about it in context here in the US, I don't know if any of you work with veterans, but when I think about people I've worked with that would be eligible for a program like heroin assisted treatment, it's like my vets, like my Vietnam vets who have been using forever, and they go on and off medication assisted therapy, and they get kicked off a lot because they come up positive for other things, or so this is like the heroin assisted treatment specifically is a last resort kind of treatment.
Mindy, do you also want to say something about, before we go on our break and share the poll results, about like starting off in the sort of NAAA world and kind of like how you came to then do harm reduction,
Yeah, so I am a person who has recovered from a substance use disorder. I know some people probably just got a little queasy by me saying that, and that's okay. I have recovered from a substance use disorder, and when I first got sober, it was through drug court. I'm a graduate of drug court. I went to a treatment facility called The Haven, and it's like a really hardcore confrontational sort of treatment, and I loved it. It was good for me. It saved my life. And I got sober in AA and Cocaine Anonymous. And I am grateful for every single day I spent in those rooms. every single day. Like you'll hear a lot of harm reductionists kind of bash on AA and 12 steps. And I think that 12 steps is a beautiful, beautiful path. Abstinence was the only way I could have gotten sober. Like I was a meth addict. Like I don't know how that would have worked, but I was like popping Adderall or something, right? So fast forward, I'd been in recovery like 7.5 years when my sister died. And all I could think was, all the ways that I could have loved her better, that I could have been a safer place for her to be more honest. Because after she died, I found out her addiction was even worse than I thought it was. And I thought, well, how did I not know? And it's because I didn't, because of my own recovery specifically, I didn't create a safe space where anybody could be anything but abstinent and their recovery be meaningful to me. Right. And it doesn't matter what I think, but it does to the people that I love and that love me, and I looked back on it too and thought, how many clients that I've treated did I make feel like their recovery wasn't enough for me? How many times have I sat at a clinical treatment team meeting and bargained for somebody's worthiness to remain in treatment because they've relapsed for the third time? And that's when after my sister died, I swore I would never do that again. And so that's why so I started UHRC, and I became a harm reductionist. And as a harm reductionist, of course, we support abstinence. I support abstinence. I love abstinence, and it's not achievable for all people, and it shouldn't be a requirement for all people. If somebody comes to me and says, I need help with my drug use, who am I? Like it, and I've heard this lots of times from all sorts of people in this profession. Well, until you get clean, there's nothing I can do to help you. Well, then why are they coming to me? Like if I'm not going to help them in their darkness, substance abuse treatment is the only treatment I've ever seen that requires the outcome before the work's been done to get there. And I could not be a part of that anymore. Having to bury my own sister, I've buried over 40 clients and many, many friends. And these are people's lives we're talking about. And I will not bargain for somebody's worthiness to stay in treatment. And I will not turn somebody away who's asking for my help. And so I started UHRC. We're a harm reduction based treatment program. We don't require abstinence to engage in treatment. It doesn't have to be your goal for end treatment. We allow medical cannabis. And we have a higher treatment retention rate than I've ever seen in the 12, 13 years I've worked in treatment. And my clients they're honest with me. They don't have to lie to me about their substance use because they know that getting kicked out of treatment is not possibly a consequence. Our only requirement for treatment is a desire to engage. So as long as people are engaging, they get to stay in treatment. You decide when you're done getting help.
Thank you so much for sharing that, because I know that's like a journey. I think a lot of us, right, grow up with these ideas that abstinence is the only way. If we know someone with a substance use disorder, we direct them to AA or NA, which are actually not treatment, they're just social support. And so that is a journey that a lot of us have been on, what Mindy describes, of course. So the poll is in, we ended the poll, and it looks like, yeah, most people are supportive of syringe distribution programs, which is great. A little bit less support of safe drug supply and safe consumption sites. And that's fine. This might be something that you're not comfortable with and never become comfortable with. It also might be something that you change your mind on over time. All of that is fine. This is just to sort of introduce some of these interventions and talk about them. So we are going to take our 5-minute break right now, so that you all can stretch your legs, use the facilities. I guess that's like the polite way to say it. So we'll take a 5-minute break. We'll come back and talk about pharmacotherapy and then do our interactive component as well. This is kind of a long, I know this is kind of a long training. The original training was, if you want to feel better, the original training was 8 hours. Mindy and I got it down to 4, and now we got it down to 2. So we're doing our very best. I don't think we can get it to under 2 because we also want to have discussion at the end. So I'm going to talk a little bit about pharmacotherapy and one specific type of treatment, right? Medication treatment. That's what we mean by pharmacotherapy, which is medications for opioid use disorders. We do recognize that, of course, there are medications for alcohol use disorders as well. But because of the sort of drug poisoning crisis focusing so much on opioid overdose deaths, we think it's best to focus on these medications and acknowledge the shortcoming of the training. So we're going to talk about the 3 that are used to treat opioid use disorders, which are methadone, buprenorphine, and naltrexone. So what are they? Of course, they're the FDA approved medications to treat OUDs. They're sometimes called, and I would say I myself still call them this a lot, which is medication assisted treatment. And I'll talk about why there's been a movement away from that, or medications for addiction treatment, or MAT. So there's been some sort of criticism about saying medication assisted treatment because of that word assisted. Because what is the medication assisting? It kind of implies there's like another primary or more, maybe more legitimate intervention that the medication is sort of helping, which is generally, right, the thought is counseling, talk therapy of some kind. But medications on their own are treatment. It's always nice when someone also does the therapy thing, but it's not actually like any less valid, right, to be, on the medication alone. And I'll talk about some of that research. So if you want to use the MAT acronym, American Society of Addiction Medicine is now suggesting that people use that to mean medications for addiction treatment. So to get rid of that word assisted, but I still say it a lot, I will say. I'm still working on the transition. Of course, other medications are used to treat alcohol use disorder that we're not really going to address today. Other types of substance use disorders don't yet have medication treatments, but there are studies sort of working on those. And there's some that are kind of promising, but they don't exist yet. So the three kinds of MOUD, or medications for opioid use disorder, function slightly differently. So methadone is a full agonist. Buprenorphine is what's called a partial opioid agonist. And then naltrexone is an opioid antagonist. I mean, they're all working on the opioid receptors in the brain. So methadone is a synthetic opioid agonist, and it's a long-acting opioid lasting about 24 to 36 hours. It is used to prevent physical withdrawal symptoms and also reducing cravings for people with opioid use disorders. It does block the effects of other opioids like heroin. When doing my research, I found a lot of people were not aware that that's a function of methadone, buprenorphine, and naltrexone, that they all should be blocking the effects of heroin in different ways, though. And patients are encouraged to stay on methadone treatment as long as they feel helped by the medication. And that's the guideline from ASAM, the American Society of Addiction Medicine. But a lot of people feel like, oh, there should be a time limit put on that. This is not a forever medication. You got to get off at some point. But that is actually not the standard of care. Patients should be allowed to stay on it as long as they feel helped by it. And any sort of cessation or tapering off a medication should be a patient-led decision between and then the patient should be talking to the prescriber and talking about kind of the social conditions around them. Are they ready for that? And supported if they do want to go off the medication, but there should not be any shaming or expectation that they necessarily have to get off the medication either. Buprenorphine, like methadone, is an opioid agonist. It's a partial opioid agonist, so it operates slightly differently in the brain. Both of these drugs are sometimes called by the acronym OAT, or OAT, which stands for opioid agonist treatments. Buprenorphine is less regulated than methadone. So part of my research is on methadone regulation and sort of how strong those regulations are and how they affect providers and patients. Buprenorphine doesn't have those same regulations, which ultimately can function as barriers, right? So buprenorphine is less regulated than methadone. You don't have to go in for daily dosing. You can get a month's supply. It's sort of treated more like a typical medication. So for patients, especially in rural areas, where Mindy and I were doing this talk a while ago, that's really important because people can't get to an OTP, or opioid treatment program, that provides methadone every day in some areas, because that's a really far away thing, and to drive daily is not realistic. So buprenorphine is a lower sort of access barrier medication, but some patients don't find it as satisfying. It's a partial opioid agonist. Some patients really find their cravings and their withdrawal are better controlled by the full agonist effect of methadone. So it's not necessarily like these two drugs are always interchangeable for people. Suboxone, of course, is a popular brand name formulation of buprenorphine. It combines naloxone and buprenorphine. It's trying to deter people from what's called misusing the medication. And by that, they mean injecting or snorting the drug, because naloxone, of course, is activated, is effective, right, when you nasally and when it's injected, versus if you just were to swallow naloxone, it wouldn't work. So when you swallow Suboxone, it's not doing anything to you. You're just getting the effect of the buprenorphine. A lot of patients and also some providers actually call all buprenorphine products Suboxone, I think because it's easier to say, but a lot of times they're actually not taking Suboxone, they're not providing Suboxone, they're providing other types of buprenorphine, and people just use that term. Of course, many of you have probably heard of the Sublocade product, which is a subcutaneous extended release buprenorphine injection. Some people like that. Patients like it too, because you don't have to remember to take it every day. It's kind of just there. Other patients don't love it because it kind of takes away your ability to make decisions around your drug use, and that can feel disempowering. So not everyone's on board with Sublocade. So that's something to think about too. Patients have the right to relapse. We don't necessarily want them to, but it's their right. Patients are encouraged, of course, to stay on buprenorphine, just like methadone, as long as it helps them. There should not be a time limit put on it. That said, Utah in the past, I don't know if they have it anymore, used to have a 3-year maximum on Medicaid reimbursement for buprenorphine. That's not an evidence-based decision. People should stay on it as long as possible. One of my best friends, her brother, is a patient in New Mexico who has been on buprenorphine for 12 years and is doing very well on it. And has other co-occurring psychiatric problems. He is not a good candidate, right, to go off of buprenorphine. He has no desire to go off buprenorphine, right? He's someone who maybe will spend the rest of his life on buprenorphine, and that's just fine, right? Naltrexone is used for both opioid use disorders and alcohol use disorders, but it's the extended release injectable one, typically known by its brand name Vivitrol, that is the one that's best used for opioid use disorders. There's not great evidence that the oral tablet version of naltrexone works great for opioid use disorders. The evidence is really weak, not very good. The evidence is much stronger for the injectable version. So again, it is not an opioid, it's an opioid antagonist. It blocks the effects of opioids and the euphoric effects of alcohol. It's recommended for people with OUD and AUD who want to reduce their chance of relapse, but it's typically not recommended for people with OUD who have a high physical dependence because it's just so hard to start naltrexone, and I'll talk about that in a minute, when you have that high dependence. So are these medications effective? Well, in terms of OAT or methadone and buprenorphine, yes, they are considered the gold standard of care for opioid use disorders. Countless studies show that these really help patients to not relapse, to not use risky drugs, and to stay in treatment. The gold standard of care, according to like SAMHSA and American Society of Addiction Medicine, is, including both the medication and the treatment. I think, but I will say there is evidence that the medication alone is still effective. There's been a lot of research on what's called medication first programs, which are programs that provide low threshold medication. So just they give you medication. They don't actually require you to come to counseling or group. They don't kick you out for co-occurring substance use, but we'll talk to you about risks related to that, of course. And this is shown to, just giving the medication alone with no counseling is shown to increase access and retention too. So the medication itself is treatment. People do get benefit from just that. Of course, though, if people want counseling, they should be provided with counseling. So these medications are more effective than counseling alone for retention in treatment and then reducing illicit behaviors, both in terms of drug use and criminal activities. There's many studies that show that these work, countless studies. I mean, we've been using methadone since the 1960s, right? So there's just so many studies out there that show that this stuff works. A particularly good study that came out of Massachusetts several years ago and had a nice big sample size. They looked at 56,000 patients in Massachusetts. They showed that people on buprenorphine and methadone treatment had way less relapses over time than people who were not taking any of these either of these two medications and were just doing sort of behavioral health talk therapy stuff. So the green line is people who were not on any medication treatment, were just getting counseling. And the blue line and red line are buprenorphine and methadone respectively. And what they found is that for basically any treatment length, the length of the treatment is the horizontal axis. And the number of relapses is the vertical axis. They found that for any length of treatment, people were at lower risk of relapse if they were using these medication treatments. So this is just one of many studies. Just an example I thought had a nice graph that illustrated the difference, that how much it reduces these risks. So are they effective in terms of naltrexone? Yes, but I want to put an asterisk there. Naltrexone does reduce cravings for opioids and it does reduce illicit drug use, but it is less effective than methadone and buprenorphine. Part of that, probably the biggest piece of the reason why that is that because it requires a 7 to 10 day detox, during which patients are at a much higher risk of relapse and overdose. The other medications, buprenorphine, methadone, don't require that length of waiting to start your medication. So studies that have kind of looked at how hard is it to actually start each of the medications, well, naltrexone is significantly harder. Only 72% of patients in one study were able to start naltrexone versus 94% of buprenorphine or methadone patients. So they lost 28% of their patients who were in the naltrexone group. They weren't even able to start the medication because they couldn't go through the detox. They couldn't be abstinent for that long. But of course, naltrexone is still better than no medication at all. So receiving counseling and naltrexone is still more effective than counseling alone. For some populations of people with opioid use disorders, such as those under criminal justice supervision who may not be allowed or able to be on methadone or buprenorphine. In New Mexico, last time I was doing research in this area too, people who were healthcare providers, nurses, physicians were not allowed, if they had an opioid use disorder, to be treated with methadone or buprenorphine. They were only allowed naltrexone, and they were only allowed to be on treatment medication for a year. I will say that is interesting because it's not an evidence-based plan. Naltrexone should not be limited either. The American Society of Addiction Medicine does not put a time limit on that. But New Mexico is not alone. A lot of states do not allow their healthcare providers who are in treatment to be treated with the most effective medications. So in those cases, naltrexone is a good option, but we can also critique whether that's really fair to that patient population. Or ask. I guess I'm critiquing. You can ask. Okay, so I do now want to ask about utilizing medications and harm reduction in your work. So our previous question kind of asked, do you think it's okay for these harm reduction interventions to kind of exist in society? But now I want to ask in terms of you and what you do. Which harm reduction interventions and medication treatments would you be willing to refer your clients or patients to? So here we're asking about the harm reduction interventions and the medication treatment. And again, assuming safe drug supplies were legal, would you refer people to this? So again, I'm not necessarily saying, are you going to go work in a safe consumption site? But I'm saying in the work that you do now, would you be willing to refer people? Mindy, early in your work, how would you have answered that question? You're muted. You're still muted. Okay. Did you lose the window?
Finally, I kept clicking on my own copy of the PowerPoint. I was like, why is this not moving? Where's my mute button? Okay, now you have to ask me the question again because at this point I forgot what it was.
That's fine. So I know, now you would probably refer people to all of these things, but earlier in your treatment career, how would you have answered this question, do you think?
So it was interesting in the beginning, like methadone. I used to really feel like methadone was a crutch for people because methadone is the one people seem to be on the longest. Like people are on methadone sometimes for 5 years, sometimes 15, 20 years, right? And then one day it had to occur to me that what business is it of mine how people recover or how long they've been on methadone? Who cares? If the person is not sticking a needle in their arm anymore and they're not robbing a bank, who am I to decide when somebody should or shouldn't be on medication, right? So like, I think I used to lean toward like no abstinence. And then it felt more like methadone is much more, what's the word? It's more regulated and observed, has more, which means it has more barriers. So I think I used to lean a little bit more toward that one in that way, just because I felt like people should have to do these certain things in order to get medications. But today I feel very differently. I feel like people are entitled to be treated and that if they don't want counseling, they shouldn't have to have it, especially people who've been on medication assisted therapy a bunch of times. There's plenty of people who are opiate addicts who just need something to detox with, or just need to maintain on medication. Eric had said in there earlier about the X waiver, we need to remove barriers for people to even access these medications, right? Like any doctor can prescribe an opiate, but you have to go through a special training to provide Suboxone. And methadone is so regulated that you have to have a specific methadone clinic to administer methadone.
Right. Though they did get rid of the X waiver.
Yeah. Well, then I thought that it stopped. Like I thought that, oh, never mind. Don't listen to me. But I thought that they had stopped it and then brought it back.
You still have to fill out a form, but you don't have to go through the training anymore.
Oh, that's nice.
But that's very recent and not everyone knows it. And the form is still weird and assumes you went through the training. Anyway, it's very confusing.
Yeah.
But yeah, it is.
So now I'm all for whatever works for each individual person.
Awesome. Okay. And so the poll results are in and they're being shared. So it looks like people feel pretty good about methadone treatment, buprenorphine treatment, and syringe distribution, and a little less good about the others. So we'll talk more about that in our breakout rooms. I'm just going to briefly do one more section of this presentation because I want to talk about some of the barriers to services. And then we're going to talk about how could you kind of include these services in your work? What are some of the hesitations you have? Why would you or would you not? And how could you overcome any barriers? So it'll be more interactive. But so of course, there's a lot of barriers to all types of health services. There's especially some rough barriers though for accessing harm reduction and treatment services. Cost, of course, is shared by all types of health problems. But the lack of information and the issues of stigma, I would say, are a little stronger in this area of health services than others. So when I say stigma, I'm talking about stigma towards people with substance use conditions for their substance use, but also stigma towards, pharmacotherapy and harm reduction interventions. Not everyone feels comfortable with those or thinks they're legitimate. So we'll talk about that too. So the cost barrier, one of the nice things about harm reduction programs is that typically they're providing services for free, which is wonderful, right? But when it comes to treatment services, things get pretty expensive pretty fast. So when we're talking about pharmacotherapy, methadone is $13 to $15 a day, depending on the clinic and where you are. I've actually heard of clinics that are $17 a day. Injectable naltrexone around $1,400 a month, buprenorphine $350 a month. New Mexico is great, right? Because you have expanded Medicaid, but in places like Texas, these are out-of-pocket costs for most people. Even if you have insurance, you might be underinsured, which means your deductible, your copay is so high that you're not actually going to use health services because your insurance isn't covering enough. So definitely the cost barrier is still there, especially once people are sort of going the treatment route more so than the straight up harm reduction route. Also, a lack of information can be a big problem. We mentioned earlier that, Mindy and I, just probably like everyone, grew up learning about particular ideas about treatment that were abstinent-based. Maybe we're focused on AA, Narcotics Anonymous, right? That we thought of that as treatment only. So there, not everyone knows all of the services and options that are out there. And a lot of the public knowledge on substance use treatment and interventions comes from media, TV shows like Intervention, right? Those don't typically portray evidence-based interventions. And if they ever do, it's only the abstinence-based interventions pretty much. So I grew up watching Dr. Phil, Intervention, Teen Mom, Dr. Drew stuff. And I had no idea that methadone even existed, buprenorphine even existed until I started doing this work. That's where most people get their information. And the problem with this though, is that it can not just be like, oh, I didn't know it was out there. It can also fuel negative perceptions of some of the evidence-based interventions. So fueling stigma towards harm reduction. And there's actually research showing that those sorts of negative attitudes from friends, families, providers can actually lead patients to delay access to services because they didn't even know that they were there. Families aren't helping their loved ones get to it, etc. And this connects to the issue of stigma. So I think a lot of times when we talk about stigma, people think of just about sort of like negative attitudes, but stigma by definition is not just attitudes. It's when a person or group experiences prejudice or discrimination in a society because of a particular characteristic. So prejudice is that attitude piece. But there's also that discrimination piece. So being marginalized, being excluded, being mistreated is also a part of stigma. It's not just having, mean thoughts. So examples of stigma towards people with substance use disorders that have been documented in research include things like being denied care in emergency departments or primary care or pharmacies. When I was working in Texas on this research, there was a lot of accounts of pharmacies not wanting to give people their buprenorphine prescription or saying something stigmatizing when the patient came to pick it up. You really should be on this. You're not really in treatment if you're on this. Like that was a common thing that was reported by patients. Also, the thing we talked about earlier in the training, being called a junkie or an addict is stigmatizing because it's sort of labeling people for their one behavior that you don't like, as opposed to understanding they're a human being who maybe is doing some risky stuff. And then this isn't just about individuals and our attitudes and how we treat each other. This is also about a broader structural issue in our society. So criminalization of substance use is a form of stigma. It marginalizes people who use drugs. It creates material hardships for people who use drugs that make it harder for them to be safe, to not overdose, to get into treatment. So I know that's maybe hard for people who work in the criminal justice system to think about, but the criminalization of substance use is a type of stigma that we call structural stigma, which is when policies or the people who carry out policies marginalize individuals from a particular group. Here, the group is people who use drugs, right? The effects of this stigma are wide reaching, and a lot of the research on stigma is new, but we've got some pretty good evidence that this is really harmful, that these phenomena are super harmful. It causes emotional distress, which is a health problem, right? It's not just feelings. People feeling stress, emotional distress has a health effect on their bodies, right? We want to avoid that. Also, it has material effects, homelessness, discrimination in housing. Landlords are allowed to ask about past convictions, and they're allowed to not rent to you because of those. Avoiding treatment is probably one of the biggest ones. People who feel stigma, they don't want people to know I have a substance use disorder, are more likely to delay or avoid treatment altogether because they're worried about what people think, and they don't want people to find out they have a substance use disorder by going to get the care they need. There's also, of course, as we mentioned earlier, stigma towards harm reduction interventions and medication treatment. So people can be shamed for using these things. And then people like Mindy, who work in these services, can also be shamed or stigmatized as well. It's not just patients in this case. And this sort of stigma can come from actually people who work in treatment. So I have a study about this that talks about individuals urging patients to stop medication treatment. So not asking the patient, are you ready? But just telling them you shouldn't be on that, denying counseling services to people who use MOUD or medication treatment or still use illicit drugs. Those are types of stigma. Also, this stigma can result in, delaying medication initiation. It can result in people hiding their harm reduction and medication use from their family, their friends, their employer, their primary care doctor. It can also lead to people stopping medication treatment prematurely, which puts people at risk of overdose and death. So the stigma stuff is a problem, the cost stuff is a problem, the information barrier stuff is a problem. So how do we start to try and overcome some of these barriers in the context of all sorts of different health services? It's a tough question. And what I hear a lot is a lot of hesitations towards engaging in this stuff that I think I understand. And you're not alone if you feel these things. They're really, really common. I hear this from almost, half the people I talk to about this stuff. So a lot of people think, well, I hear what you're saying. I know there's an evidence base there, but I really just feel like harm reduction at its core encourages drug use. Or I feel like medication treatment should only be used for a short time. Otherwise, you're basically just using heroin again. Or if I offer medication services, those patients are going to cause problems and I could get in legal trouble, right? I'm liable for what happens and what they do, right? If they sell their methadone and my name's on that bottle or my name's on the buprenorphine prescription, how does that look for me? Or if I take on substance use disorder patients, other patients will be turned off from my office. So a not in my lobby type of attitude. A lot of people feel this way. These are barriers, though, to working with these services. And I would argue that these hesitations have some real effects, and so we should work on them. This can lead to people, rejecting substance use disorder patients, so the patients have nowhere to go. It can also mean, providers are refusing to engage in evidence-based stuff and harm reduction and pharmacotherapy. I acknowledge these concerns. I think they're real, but I do argue that harm reduction and medication treatment can be effectively integrated into all health and social services. I really think there's a path forward for health services to embrace this stuff. But embracing this stuff also means policies, leaders, and people providing services have to change. And that's a tough thing to ask, right? And when we talk about change, it's not just a change in like, I will refer to services, it's a change in values. Like we said, harm reduction is not just interventions, it's also values. It's the way you approach and see your work and see people. And, we tend to come to treatment work with this sort of idea that all of treatment's goals is to move people along the substance use spectrum that Mindy mentioned earlier, right? You have a spectrum where you have people with an addiction diagnosis on the right side, and then you have abstinence on the left side. And the goal is always to move people from the right side over to the left side. Well, harm reduction is asking you to say, yes, that's a goal, but we can have other goals and those are legitimate. And it's asking you to set up services at your work site that allows this to happen and helps people with this. So things like, maybe we don't move someone, maybe they are going to still have a substance use disorder and it's severe, but we're just going to make sure they don't die. Or maybe we're going to help them reduce their use significantly, but they're still using. And then other people, of course, if they want it, we're moving them to abstinence and supporting that journey as well. So this is the tough thing, right? Is reorienting health services that have focused on this abstinent approach, this traditional model, to embracing more goals, the many goals of harm reduction. So we are going to go into breakout rooms for, let's say about 10 or 15 minutes, I'm not sure. We have time for 15. And I want people to discuss with other individuals who are interested in these issues. You're all interested because you're here, to discuss what are some of the barriers to using harm reduction or pharmacotherapy in your work, any of the interventions we talked about today. And then in what ways could you maybe overcome these barriers to use harm reduction or pharmacotherapy in your care for people who use drugs? Because I acknowledge the barriers are there. No one is saying they're not there, they are there. So what could you do to overcome them? Mindy, do you want to add anything before we send people to the breakout rooms to do some discussion?
No, I feel like we'll probably discuss it in the breakout rooms, right? Or are we going to be in a breakout room, each one of us? Or they'll just break out?
No, just them.
Okay. I'm so interested to hear what kind of barriers you have in New Mexico, because I feel like you don't have any, like other than the barriers that are New Mexico in itself, right? Like you guys have some rural areas that are impoverished, like I've never seen here in Utah. It made me cry.
Yeah, well, they'll report back. So maybe we can give
report back. I'll be waiting. I'm so excited.
Christina, maybe we can do 10 minutes in the breakout room. So I hope you all will stick around and actually engage in the breakout rooms and talk about it. And then we're going to come back and report back and then have a Q&A as well.
Perfect.
So Christina's setting those up right now.
Okay, the rooms are open. Erin and Mindy, please ignore the invitation you just.
Okay, I was wondering.
That's so funny. I was like, I'm joining anyway. No.
So when you see the pop-up for the breakout room, you click join, and then you can add it and have a small group discussion, introduce yourself, and talk about the questions.
Wow, that's a lot of breakout rooms.
Yeah, we've got 5 to 6 people in each room.
Sounds great. Thank you, Christina.
Sure.
You know what's crazy? While we were in here, I just got an email from Jennifer Plum at Utah Naloxone with the same CDC data. Those are the highest overdose death numbers recorded in American history from 2020, which that makes sense to me because like I lost a lot of people in 2020, like people who were in long-term recovery. That's sad.
Yeah, and you can only imagine how much worse it would be if they hadn't made the COVID changes for like methadone clinics. I feel like it would have been even worse.
Yeah, that's really scary. And I got an email too from the New Mexico I think it's from the Department of Health. You guys are doing, like, the Department of Health down there is doing a presentation on cannabis as a harm reduction tool.
Oh, cool.
Yeah. My God, New Mexico. I might just pick up and move down there.
I know, like I want to move back.
I love Santa Fe, Albuquerque, and I feel like I will love Roswell. I'd also like to go to the other one that's by Corpus Christi. What's it called? The town that's on the It's like close to Corpus Christi, Texas, and El Paso, I think. Or maybe I'm off about Corpus
Corpus
Christi.
Christi's
Maybe
on
it's El
the
Paso. What?
Corpus Christi's on the Gulf.
Okay, then scratch that one. It's the other one I just said. El Paso. It's close to El Paso then maybe.
Las Cruces.
Las Cruces. That's where I want to go. I have a bunch of friends in Las Cruces.
I like Truth or Consequences. It has hot springs. I recommend.
I love that there's a place with a name, Truth or Consequences. I
Yeah.
also saw that there is a fraudulent Las Vegas in New Mexico as well. I saw somebody here is from Las Vegas, New
Those
Mexico.
are fighting words. Be careful.
You have to put an M behind where you live. It's not a single human being besides New Mexicans know that there's such a place.
Yeah.
I was like, Las Vegas, New Mexico. What just happened here?
I was confused when I first moved to New Mexico in 2013 and people kept talking about Las Vegas. I was like, what?
You're like, are you lost? Why? Where did the name Truth and Consequences come from? Do you know? I feel like that's the first thing I'd look up if I moved to New Mexico. I'm gonna look it up today anyway. If you guys don't know,
I think it was named after the TV show, the old
What?
black and white. Yeah, there was a black and white TV show, and this little town named themselves after it.
wow. They're like, you know what? We're changing our name.
Yep.
You guys, we had so many people ask about a certificate of attendance that I just made one. And so it's just a PDF and they can fill in their own name. But if you would just announce that in the end, and then I'll drop it in the chat and people can just grab it.
I can absolutely do that. If I don't, you can always interrupt.
I'll pop in
We're
if you
doing
don't.
good on time,
Okay.
shockingly.
And I have a timer going, by the way, for the breakout rooms, just so you know. We have about 11 and a half minutes left.
I can't wait to hear what they say.
Yeah, yeah. There were two groups with two, so I combined those.
Okay.
Waiting to get into rehab in New Mexico is a huge barrier. Dude, what do you guys do about, so like when I was in Espanola, so like the trailers are what, 5-10 miles apart a piece, you know, and they're in the middle of nowhere. Like, how do people even access treatment in those kind of places?
Espanola actually has an okay hub of treatment providers, like just in the town.
I
But
must have missed the town entirely.
there is a little town. It's got a Walmart. It's got a Taco Bell. But Espanola is actually like a little bit better. Espanola, Santa Fe, Taos have a few more treatment centers than some of the other parts of the state, but it's just almost impossible. And you know that you have to strike while the iron is hot, and you just have to call and call and call and call. And by the time you get something, most often the person is no longer interested or has another plan. And
How do they get, like, is there public transportation in Espanola, or like for the people who were on those rural outskirts where I was out doing the syringe exchange with them? How is there public transportation helps those people get somewhere? Or
I don't know what specifically they have in Espanola. I wonder if some of those treatment centers might come get you, but in Albuquerque, like I'm in Albuquerque, and anytime you want to get somebody anywhere, it's driving them to Santa Fe. I mean, there's a detox here, but even like in our ER, the ER doctors will say, I wouldn't recommend that place for anybody. I wouldn't send my loved one there.
wow.
So that's how good it is. But then there are a couple of good places in Santa Fe, Espanola, Taos, but it's always a matter of like driving somebody. So it's usually somebody from the recovery community who, you know, networks and gets somebody else in their car.
Wow.
You know how people do.
Yep. I was just hoping that maybe New Mexico had some kind of magical answer to like the transportation kind of issue.
I don't think so.
Huh. That's unfortunate.
I mean, even in town in Albuquerque, it's not great. Like,
I was thinking that. I mean, I feel like that's one area that we do still really have a lag in.
Well, I guess I won't be copying that from you guys then.
yeah. I was gonna say, the only place I've lived with worse public transportation than Albuquerque is Detroit. So
Really?
How is Detroit, Aaron?
I love it, but it's awful. A third of the population doesn't have a car, and we have the worst bus system in America. It's shocking.
We
Albuquerque's
also have the worst financial management of any state in the whole country as well.
yeah.
Michigan's coming out of it. They're trying.
Yeah.
Yeah.
So I'll stop sharing. And then before we go, I'll share my screen again so that people can have our email addresses. I'll put that up in the thank you and everything. Well, I hope the breakout group discussions were helpful. There's still a few people coming back because we give, yeah, now everyone's coming back. Great. So welcome back. I hope that the breakout group discussions were helpful. In the past, Mindy and I have actually done this presentation in person, and we found that the small group discussion was helpful for people to think about how does this apply to me, my job, my work, whatever. Trying to recreate that in Zoom as much as we can, it's a little hard. But then we would also like to hear what y'all talked about, report back on some of the conversations you had about these issues of barriers to engaging with harm reduction and have function. Do we have that?
Yeah, we all should have the raise hand function. If you look to the bottom part of your screen and you see a little reactions button with a little smiley face, and you can raise hand or do a thumbs up.
Great. I see Eric Lemke raise his hand. Do you want to unmute and share?
Yeah, good afternoon, everybody. My name's Eric Lemke. I'm a peer on the Peer Opioid Project. I work in the Downtown Emergency Department of Presbyterian. And one of the barriers that we were talking about is just having a safe space for an individual to actually be honest about and talk about their drug use without the stigma being attached. I noticed it here in the emergency room. I've been down here since October of 2019, and it was pretty prevalent the way that people were being treated or not treated, or just the way they were being addressed. And my hat's off to press, because they have actually made part of their onboarding process for all the nurses and the techs and stuff that work in the emergency department. They meet us and the community health workers that I work with before they ever go out on the floor. So they get to hear part of my story about it, what it's like to be an addict in the emergency department and be treated that way. And now we have patients that are actually asking to come to our hospitals because they have peers, and it's becoming a safer place where they can have those conversations with the doctors. They can ask questions about buprenorphine, and we have an induction program here where they can be induced on bupe. They'll get sent with the 3 or 5 day primary that will continue that support for them. And just seeing the change and having a safe place to communicate what's actually going on and not having to play the game with the doctors and the nurses has been amazing. But it's just the beginning. There are so many other aspects that need to be addressed. But that's one of the ones that we talked about in our.
Thank you so much. Oh, go ahead.
That's funny. We were just talking just a second ago. Sorry about the health. Like, that brought tears to my eyes, Eric. Which, by the way, you've had really great feedback in the chat all day. But that almost brings tears to my eyes that people are asking to come to your hospital. That people want to interact with your medical staff, and that you have peer supports there to help navigate people through the medical system, because it's one of the most biased systems that we have toward people who use substances, and it's probably one of the it might be the most unsafe place to not be honest. You know what I mean? Like, if you're not being able to be honest with a medical care provider, we literally were just talking about how that is so dangerous on so many levels. Thanks for the work you're doing.
Did anyone else want to share some of the things they talked about in the breakout room? Martin. Oh, you gotta unmute. There you go.
All right. One of the things that I personally brought up was that, you know, here where I live, one of the barriers that we run into is, you know, given the nature of the town, Santa Fe being a tourist destination, one of the barriers is having the business community buy into supporting addicts, alcoholics, along with homeless people and that kind of thing. It seems like addicts, alcoholics are not seen as part of the community. And, you know, addicts and alcoholics, the idea of admitting we have a problem is bad for business. So I think that's one barrier that we run into up here, is having, you know, the business community buy into this idea of taking care of citizens of the town.
So how does that kind of like manifest? Do they push back on things like mobile syringe distribution being visible? How do you see that kind of playing out, their opposition?
Well, first of all, we don't want the people visible. Don't want them gathering on the plaza, don't want them out in public. You know, yeah, I think engaging people in those kinds of discussions, they obviously are happening, but not in public. They're not open discussions that I know of. I've worked here in this field in Santa Fe for 30 years, and there aren't any public forums that I know of that are working to address the things that we've been talking about today. Even the hospital, one of the major hospitals here in Santa Fe, you know, they have a psychiatric unit, but they refuse to use it. You know, they send people out of town. So it's like, yeah, we, you know, it's kind of like if you ignore it or you don't acknowledge it, it doesn't exist thinking. That's it.
Yeah, thank you for sharing. Anyone else want to add or have anything in Santa Fe that they noticed too? Dr. Page?
I think David Sanchez was in our group and he could talk about what we spoke about. He had some really good insight too.
All right. So one of the things that I had mentioned is that I'm in the area of Chaparral, which is about 5 miles from El Paso. But one of the biggest things that we see is transportation, because we don't have the resources. We don't have buses. We don't have Uber. We don't have the vans that Dr. Page was talking about that could pick you up at your house and then take you to these locations. And without the transportation, it's a big barrier, you know, as we all know, but especially in a rural community, because, you know, from like to reach the Department of Health, a house could be like 10, 15 miles. And we're in a rural community where we are centralized. Another thing that we had talked about was being stigmatized, you know, not wanting to get services because, you know, you're going to be judged, or families that don't know about what, I don't know, just know certain things about you that you want to keep private. The other thing that we had talked about also is legislation, changing the age limits, or the barriers that are people that are coming, that are imposed due to policies that are in place, especially in New Mexico. So those are the things that we were talking about. To overcome those barriers, we were discussing, hey, Dr. Page had mentioned vending machines where these people can get clean supplies, going to legislation to change policy, changing people's perception of to not judge people seeking help. Because that was one of the things about the transportation that we had mentioned about. And I had mentioned, like, yeah, it's true. We judge people, and these people that we're judging, why do we want to provide transportation to those type of people? And that's the mindset that we have here. Well, this community. And that's why it's really hard to find resources or help. So that's what we had discussed.
Don't you think, David, that what Catalina said was, really stigma is the big barrier?
Yes. It was the biggest barrier.
Yeah.
I'm here in Rio Arriba County, and we have a very big high stigma problem. In fact, we're trying to put together like a community event to hold like a stigma, some kind of like training on stigma for people not to, like you were saying, judge a person. The other day we had a meeting with Lupe Salazar from Barrios Unidos here in Chimayo, right? And she was saying on Facebook, somebody posted like a picture, and it's about like psychology and stuff like that. And there's a guy in a hole. So a doctor passes him, and like an MD, and throws pills at him. Like 4 or 5 different physicians, medical people pass him, and they just like do the bare minimum. And then somebody that has been there, peer support, or I think a drug and alcohol counselor, I don't remember who it was, got in the hole with him. They didn't leave him there. They got in the hole with him and helped him come out of the hole, right? And that's what we're trying to do. But people see people that are drug addicts or using drugs the wrong way, and they right away stigmatize them, not knowing where they once come. I know a lot of people, some people were doctors, some people were nurses, some people may have even been a lot of the people's colleagues here, and some made it and some didn't. And instead of stigmatizing and making these people feel more like shit than what they already do, like kicking them while they're down, we need to help them come up. Like how they have the woman empowerment. Let's do like, I don't know. I know you guys were saying earlier to avoid like the certain names that we put on drug addicts, like junkie and this and that, but like use it to our advantage. Do you know what I mean? They are who we are. And me being an ex-addict, well, I am who I am, and that's what made me, and that's what made me be where I am today. So not having people stigmatize you just because of what you're doing. Maybe something tragic happened and they couldn't cope with it. They didn't have the right skills, so they used drugs, and they were weak-minded, or they just really loved it and didn't have no self-control, and it overtook them. We don't know their story. So just taking a step back, or taking the time to get to know somebody without judging them, but do it sincerely, because there's people that say, oh, yeah. And then they look at you like they're afraid to even talk to you or touch you, like if you have a disease or something. And how does that make the person feel? It makes us feel like shit, to where like, we don't even want to come to your building no more. We don't even want to talk to you. For what? You just made me feel like shit. So why should I come to you for help? And I think that's a lot of the problem.
Thank you, Carolina. So we're running out of time. I do want to mention that we'll send participation certificates to everyone. And for anyone who has to leave, I understand, but we'll keep going for a little bit longer. Phil had his hand up.
Hey, I didn't know if I had anything too critical to add in the final minute, but just that when we had communicated, hi, Mindy came out with us a couple of years ago, and spent the day with us driving around here in the north. We had, I think our biggest challenge up here has been recruiting people, licensed people to come up here and work with us. We've successfully implemented a Suboxone program through our up here, but we've only been able to really get that happening by collaborating with UNM and getting a doctor from the ASAP clinic working with us, which is great. And it's allowed us to expand into, I think we're treating our first person for Hep C finally, and all kinds of other things. Yeah, we had ads up forever and ever for a nurse practitioner or MD to come up here and work. People don't want to do it. We've been looking for a licensed therapist forever, and we get all kinds of responses to our postings for people that want to work in Santa Fe, but nobody wants to come to Espanola. I think it was just shared in our group that UNM also experiencing, the hospital experiences the same issues, and our hospital up here in Hispaniola experiences that same issue. They're mostly staffed by traveling folks, and that adds to some real difficulties with the competency that people have and how they treat people when they show up at the emergency room and for other services. I navigated a patient into our ER a while back, and everybody in the back of the ER all had Southern accents. Right? None of them, none of the people that I talked to while I was talking there were from, anywhere near here. And so I think that, that speaks to a larger issue that, New Mexico has been grappling with for a long time. And that is being able to, people, I know that they put a clause in the accelerated nursing program at the community college that you have to agree to stay in New Mexico for 3 years after you graduate, because people were going through and getting that certification and bailing on the state. So I think we do a real good job with harm reduction and stuff here, but I think those are the types of challenges that we've encountered in trying to expand the scope of the work that we can do to accommodate the communities that we work in here in the rural north.
Thank you so much, Phil. That's really important points. I'm gonna have us go over a little so we can hear from Brandon maybe quickly.
Yeah, so in our group, there was a barrier that someone mentioned about willingness as being a barrier. And I work under Dr. Kim Page. And one thing that I love about our group that I hear constantly about what our group says, I was one of those people that had a really bad stigma, but I want to be an MD one day. And I knew I had to change my mindset in order to be like Mindy said, if someone's coming to me for help, I don't want to turn anybody away. There's a reason they're coming to me. And so to change that mindset, I joined the group. And one thing that they say all the time, I don't know if they notice it, but is we have to meet people where they're at and not judge them for where they're at, and kind of just walk that path with them. And I think that was one way that we could deter the barrier of stigma.
Can I please say something? I'm trying to hit the reaction button, but I only get a thumbs up or a clap. So I don't know if I can just really quick share something with you guys.
Sure, go ahead.
So I'm David from Albuquerque Healthcare for the Homeless. We have a model that from what I'm just from listening to you guys, we actually have a model that, so we do the biggest exchange program in the city of Albuquerque. We have a mobile unit that we take out in the community. Let's see, three times, there's an outreach site base on the west side, one in the downtown area, and one on the east central area. Friday nights, that's when we go out on Friday nights. It's a 4-hour outreach, and we do an average, we see an average of about 200 people in that during that time. And the great thing that we do there is that we're actually able to, we have a medical team that comes out to the outreach. Dr. Tree and Dr. Green are able to see people on the spot. We have a mobile unit that is, where people can actually go in and stuff. Dr. Tree and Dr. Green can actually treat people on the spot to treat abscesses, which is something that we see a lot of because of the stigma. People don't want to go to the ERs and stuff because they've been treated so poorly that they wait until the last possible minute. Well, again, our medical team is able to treat them on the spot, to do the, whatever they need to do, provide them with antibiotics and all that stuff, right? And then with that, of course, comes the possibility of connecting people to services to our clinic in the downtown area. The other thing is that Dr. Trey and Dr. Green are able to start people on Suboxone. That's the other thing that a lot of people, are really interested in that. And again, our approach, of course, is the one that, because of that non-judgmental approach that we are always very aware of, people are very honest with us. They're able to, because they know that this is about them, they're able to be very honest about what they need, about what they, if it's a relapse, if it's, whatever it is that they need, they know that they can come, they can talk to us, and we are going to, again, that non-judgmental approach. We're going to provide what we, the services that they might need, and then go from there. That's like, nothing's going to kick them out of the program. Nothing's going to if you're doing good this week and then next week things didn't go as well, whatever, it's still okay. We are open and we are here to provide those services with that approach. And that really, really works really, really well for us.
Thank you. Yes, I'm very familiar with your work. My mentor, Miriam Kamarami, used to work for y'all, of course. So
Right.
A lot of respect for what you all do. Really important. I do want to just say that I'm going to put me and Mindy's contact information and here are our email addresses, because I know we didn't get a chance to really do a Q&A. We are well over time. I want to thank everyone for sharing so much about the work they're doing, barriers they're encountering in Albuquerque and beyond in New Mexico. Really appreciate your attendance and being engaged. We always wish this could be longer, but we can't keep you forever. So I don't know, Christina or Dr. Page or Anne-Marie, if any of you want to say anything before we end, or Mindy.
Thanks for having me.
I want to thank everyone for coming. I know some people have dropped off with the time thing, but we're going to continue to have more of these, and we hope to invite Aaron and Mindy back to talk specifically about an issue that I think that has emerged even today, which is how can we change stigma? So be thinking about that, and we'll be inviting you back.
Bye, friends.
Thank you all so much for coming.
Bye-bye.